Hello, everyone. We still have some folks joining, so we're going to give it just another minute before we get started. Hello, everyone. We still have people joining, so I'm going to give it just another minute or so, and then we'll go ahead and get started. Okay. Well, thank you all so much for joining us today. My name is Christina Feather-Stolitka. I am a health IT advisor here at the Kentucky Regional Extension Center. And I'll be presenting today's slides on the Medicare Promoting Interoperability Program for hospitals. We are using Zoom today for our webinar instead of WebEx. So if we experience any technical issues or audio problems, please let us know. My colleague Robin will be monitoring the chat box for us. Okay, so first I'm going to cover the Stage 3 Medicare Promoting Interoperability Program requirements for 2024. I'm going to highlight the most recently released IPPS final rule, and then finish up by reviewing some action items and reminders as we close out the calendar year and prepare for upcoming attestation submissions early in the new year. Okay, so let's go ahead and jump right in. I'm not going to spend a lot of time looking back, but as a brief reminder of how we got here, the American Recovery and Reinvestment Act of 2009 mandated that CMS incentivize hospitals to adopt, implement, and upgrade certified EHR technology and demonstrate meaningful use. In response, the EHR incentive program, formerly known as Meaningful Use, was introduced in 2011 under the Health Information Technology for Economic and Clinical Health, or HITECH Act. CMS initially implemented the program in progressively more difficult stages and then offered incentive payments. Now, those incentives continued through 2016 for most hospitals, depending on which year they started in the program. And then although the incentive phase of the program did, hospitals must continue to participate in the program each year to avoid a downward Medicare financial adjustment. As we progressed through stages 1, 2, modified stage 2, and now stage 3, CMS has maintained their underlying focus on the adoption, implementation, and advancement of CERT through an evolution of objectives, measures, and electronic clinical quality measures. More recently, CMS overhauled the program in an attempt to improve flexibility, relieve burden, and place emphasis on measures that require the electronic exchange of health information between providers and patients. They really shifted their focus to improving patient access to health information and advancing interoperability. And these changes moved the program beyond the previously existing requirements into a new phase of EHR measurement. So the Medicare Promoting Interoperability Program, as you know it today, includes a set of objectives, measures, ECQMs, and other requirements that together define whether an eligible hospital or critical access hospital has met the minimum standards to be considered a meaningful user. For those who do not meet the minimum program requirements, meaning they're not meaningful users of CERT, they do receive that Medicare financial adjustment. And remember, unlike other programs, the Medicare PI program for hospitals has no defined end date. All right, so to begin, I want to point out several noteworthy updates for this program year. First up, a new measure, the Antimicrobial Use and Resistance, or AUR measure. It's a surveillance measure under the public health objective. This year, hospitals must report a yes attestation to having conducted the Safer Guides measure. In 2022 and 2023, a yes or no would fulfill this measure. That is not the case in 2024. Another big change here for this year is the minimum length of time for the reporting period. It is no longer 90 days. CMS doubled that time frame for 2024, requiring a minimum of any continuous 180-day period. And then lastly on this slide, the severe obstetric complications and cesarean birth ECQMs are now mandatory. This slide lists the framework of the Promoting Interoperability program. So as I mentioned on the previous slide, in 2024, the reporting period is now a minimum of a 180-day period. As always, hospitals may select a longer reporting period up to and including the full calendar year, which interestingly for 2024 is actually 366 days. In addition to reporting the required objectives and measures, hospitals must also submit 4 calendar quarters of data for the electronic clinical quality measures. Similar to last year, hospitals are required to use the 2015 edition Cures update criteria to meet the CERT definition. Hospitals must provide their CMS identification code from the Certified Health IT product list, often referred to as the Chapel or the CHPL site, and that's available on healthit.gov, and you input that when submitting your data. The security risk analysis measure continues to remain a requirement of the Medicare PI program. It is imperative in ensuring the safe delivery of patient health data. Hospitals must conduct a review, a security risk analysis of CERT, including addressing encryption and security of data, and implement updates as necessary at least once a year. And it is acceptable for the SRA to be conducted outside of the reporting period. However, the analysis must be done within the calendar year. So keep in mind, while it remains a mandatory requirement of the Medicare PI program, it is not scored. Hospitals must also attest to the safety assurance factors for EHR resilience, or the Safer Guides measure. CMS will continue to implement the same performance-based scoring methodology. A total score of 60 points or more will be required to satisfy scoring and successfully attest. And then lastly, the attestation submission deadline for program year 2024 is set for the end of February, so February 28th, 2025. Okay, for 2024, hospitals are required to report on 4 objectives. This slide provides a visual of the point distributions broken down by measure. Electronic prescribing, so generating and transmitting permissible prescriptions electronically, and then the query of PDMP measure. Health information exchange encourages and leverages interoperability and promotes health IT-based care coordination. And there are 3 options again this year: the support electronic referral loops by sending and by receiving and reconciling health information, or one of the alternate measures, the engagement and bidirectional exchange through HIE, or the new enabling exchange under TEFCA measure. Next is the provider to patient exchange objective, so giving patients electronic access to their health information. And then lastly, the public health and clinical data exchange requires reporting a yes on 5 public health measures, and then either the public health registry or clinical data registry reporting measures remain optional and available for bonus points. Let's go ahead and dig into some of the details. The electronic prescribing objective consists of two measures, the e-prescribing and query of PDMP measures. They're both required, worth 10 points each. For the e-prescribing measure, medication orders for permissible prescriptions must be queried for a drug formulary and transmitted electronically using CERT. And then the query of PDMP measure, similar to last year, it is no longer optional, it is required, and the hospital must use data from CERT to conduct a query of a PDMP for prescription drug history. It has 10 assigned points, and CMS is no longer limiting it to Schedule II opioids. Schedule III and IV drugs are included as well. And I'll also just add regarding the PDMP measure, CMS requires the query of the PDMP for prescription drug history to be conducted prior to the electronic transmission of the prescription. And given the variance in state level requirements and actions used to perform the query, CMS has said healthcare providers have flexibility to satisfy this measure by querying the PDMP in any manner legal and practicable in their state. The query of PDMP measure does not specify whether provider's CERT connects to PDMPs directly, and documentation should be retained on policies and processes to support the measure. Overall, you want to have evidence that you have the functionality in place to support the measure, that you performed this action that CMS requires, and that you did so during the reporting period. Next is the health information exchange objective. There are 3 different reporting options. You only have to select one of them. The first option includes completing the sending and receiving loops. So for the support electronic referral loops by sending health information measure, the hospital that transitions or refers their patient to another setting of care or provider of care must exchange a summary of care record using CERT and electronically exchange it. The second part to complete this is option 1 is support electronic referral loops by receiving and reconciling health information. So for at least one electronic summary of care record received for patient encounters during the reporting period for which the hospital was the receiving party of a transition of care or referral, or for patient encounters during the reporting period in which the hospital has never before encountered the patient, the hospital must conduct clinical information reconciliation for medications, medication allergies, and current problem lists. So both of these two together, sending and receiving, are option 1. To earn points, you must submit a numerator and denominator for each, worth up to 15 points each, and there are no exclusions. The second option is completing the HIE bidirectional exchange measure. So the hospital must attest that they engage in bidirectional exchange with an HIE to support transitions of care. For this option, the hospital must attest yes to participation in an HIE to enable secure bidirectional exchange of information to occur for all unique patients discharged from the hospital, and all unique patient records are stored or maintained in the EHR during the reporting period. Must attest yes to participating in an HIE that is capable of exchanging information across a broad network of unaffiliated exchange partners, including those with disparate EHRs, and not engaging in exclusionary behavior when determining exchange partners. And must attest yes to using the functions of CERT to support bidirectional exchange with an HIE. So that is option 2, bidirectional, and it's a yes or no worth 30 points. And the last option, 3, enabling exchange under TEFCA measure, the hospital must attest to participating as a signatory to a framework agreement and enabling secure bidirectional exchange of information to occur in production for all unique patients discharged from the hospital, all unique patient records stored and maintained in the EHR during the reporting period. And the second part of this is using the functions of CERT to support bidirectional exchange of patient information in production under this framework agreement. So this measure is also a yes or no. Attestation, it's worth 30 points. And again, you only have to choose one of these 3 options to meet the program requirements. Next is the provider to patient exchange objective. So the patient must be provided timely access to view online, download, and transmit his or her health information. And the hospital must ensure that the patient's health information is available for the patient to access using any application of their choice that is configured to meet the technical specs of the API in the hospital cert. And there are no new updates with this one. The measure's worth up to 25 points, and reporting is by numerator denominator, and there are no exclusions available. All right, lastly, the public health and clinical data exchange objective. So these are the measures that a hospital attests yes to being in active engagement with a public health agency or clinical data registry to submit electronic public health data in a meaningful way using CERT. And most Kentucky hospitals have been meeting these public health measures through KHI, the Kentucky Health Information Exchange, and will be able to continue doing so except for the AUR measure. This year, hospitals must report on 5 measures, which include immunization registry reporting, syndromic surveillance, electronic case reporting, electronic reportable laboratory results, and the new measure, antimicrobial use and resistance surveillance. And the latter two are on the next slide. The total points available for attesting to the 5 required measures this year is 25 points. As a reminder, CMS finalized the new AUR measure in 2023 rulemaking, but will be the first time that this measure is available and required. Antimicrobial resistant infections are caused by pathogens that no longer respond to the drugs designed to kill them and directly threaten patient and population health. CMS said an effective national response to that threat requires robust systems for collecting, analyzing, and using antimicrobial use and resistance data to direct action. CMS believes that requiring the AUR measure under the Medicare PI program will enable the development of a true national picture of the threat posed by overuse and resistance. Requiring AUR reporting will produce inpatient benchmarks that can be used to guide clinical and public health action. Completion of this measure shows that the hospital is in active engagement with the CDC's National Healthcare Safety Network to submit AUR data for the reporting period and receives a report from NHSN indicating their successful submission of AUR data for the reporting period. Okay, there are 5 bonus points available for hospitals that choose to submit the public health registry or clinical data registry. And you only have to choose one. You don't have to submit for both, and it's 5 points altogether, not 5 points each per bonus registry chosen. All right, before we move on, I want to review the active engagement options. So if you recall, CMS recently consolidated and renamed these options, along with requiring hospitals to report their level of active engagement during attestation submission. So option 1, pre-production and validation, means that the hospital registered to submit data. Registration was completed within 60 days after the start of the reporting period, and the hospital is awaiting an invitation to begin testing and validation. Then the hospital begins the process of testing and validation of the electronic submission of data. Hospitals must also respond to requests from the public health agency or risk not meeting the measure. And then option 2, validated data production, means the hospital has completed testing and validation and is electronically submitting production data to the public health agency. So again, for our Kentucky hospitals, if you have questions regarding your hospital's public health reporting status, again, with the exception of the AUR measure, I recommend that you contact your KHI outreach coordinator, and Robin or myself will be happy to help you all get in touch with them if needed. Okay, last slide on public health, I promise, but definitely worth drawing attention to again. So, new this year, beginning in 2024, CMS will require hospitals to limit the duration of their time on option one of active engagement to a single reporting period. So, for example, if a hospital submits a level of active engagement at option one, for the electronic case reporting measure in 2024, then the hospital must move to and report a level of active engagement at option two, the validated data production, for the next reporting period for that measure. So 2025 in this example, or it would fail to satisfy the public health objective. Their goal is for all healthcare providers nationwide to be at the validated data production stage so that data will be actively flowing and public health threats can be monitored. CMS originally proposed this to begin in 2023, so we are grateful that they delayed this requirement by 1 year, but the time has now come. So CMS stated that without this requirement, facilities can kind of just linger in registration or testing and validation for years, which provides little benefit to the public in a public health emergency to address health threats. And I flagged this one because if you are a hospital who's been working on a public health measure for a few years now, or, stuck in testing and, had been getting through by having your K-high addendum side, you're not getting you are getting a little nudge here, a not so gentle nudge by CMS to move forward into production. And I know this is going to impact a lot of hospitals. This is a big one. Robin and I have actually coined the phrase live by 25 to help everyone remember this. So we've joked that we're going to get live by 25 t-shirts made. So let us know if you want one. Haha. All right, moving on now to clinical quality measures. To successfully participate in the Medicare PI program, CMS requires hospitals to report on clinical quality measures. These ECQMs are selected by CMS and require the use of CERT. CQMs are tools that help measure and track the quality of healthcare services provided by hospitals. These measures use data reported from EHRs that are associated with healthcare providers' ability to deliver high quality care or relate to long-term goals for quality healthcare. They help ensure healthcare systems are delivering effective, safe, efficient, patient-centered, equitable, and timely care. In 2024, hospitals are required to report on at least 3 ECQMs of their choice, along with the mandatory measures. The reporting period for hospitals is the full year, so 4 quarters of calendar year 2024 data. The table on this slide lists all ECQM options available to report on in 2024. So the mandatory measures are the first 3 on this list. The safe use of opioids concurrent prescribing measure is required again this year, aiming to reduce preventable mortality and the costs of adverse events. The severe obstetric complications and cesarean birth ECQMs, and then the self-selected ECQMs may be chosen from the remaining measures here on this list. There are no performance thresholds to meet, but the clinical quality measure data must be reported exactly as generated by the hospital CERT and submitted through the hospital quality reporting system using any combination of QRDA Category 1 files, zero denominator declarations, and or case threshold exemptions. Moving on to scoring now. Hospitals are required to report measures from each of the 4 scored objectives, with performance-based scoring occurring at the individual measure level. The scores for each of the individual measures are then added together to calculate the final promoting interoperability score, which is capped at 100 possible points. Similar last year, in 2024, a total score of 60 points or more will satisfy the CMS requirement. Hospitals scoring below 60 points will not be considered meaningful EHR users and will be subject to Medicare payment reductions. Remember, hospitals must report on all of the required measures to earn any score at all. So if you submit a 0 in a numerator or denominator, or if you report a no for the yes or no required measures without claiming an applicable exclusion, then you would not meet the requirements and would earn a total score of 0 for the program. And again, be subject to that downward payment adjustment then. And I'll go ahead and talk about those just for a minute. The legally mandated penalties under the HITECH Act do continue to remain in effect, and that's why success in this program is very important. I've always found it interesting how CMS describes participation in this program as eligibility, an eligible hospital or an eligible participant. And I always say, I guess that's a nice way of saying mandatory, because you don't really have a choice unless you want to be penalized. So all hospitals must continue to successfully attest to the program each and every year in order to avoid those downward adjustments. The penalties are different. The eligible hospital payment adjustment is applied as a reduction to their inpatient payment rate for the corresponding year. And then critical access hospitals, their adjustment is applied to the Medicare reimbursement for inpatient services during the cost reporting period in which the hospital failed to meet the requirements. So 101% of its reasonable cost to 100 for that year. But of course, we don't need to worry about this. All of our clients are rock stars, right? So skip through this one. Let's go ahead and take a look ahead. I'm going to highlight the latest final rule. And we got this most recent one finalized back in August. This rule always includes proposals to update payment policies and the annual payment rates, proposes updated policies for the hospital readmissions reduction program, sets new standards for the hospital VBP program, and revisions to the hospital inpatient quality reporting program, among others. But it also establishes new requirements and revises existing requirements for us for the Medicare PI program. That's the section we're all interested in, and that's the part that I'm just going to highlight for you today. And I say highlight because I'm not going to get too in depth with these. We don't want to get too wrapped up in the details since we are trying to close out program year 2024, but I still wanted to give you a preview. And then in early spring, we will host a 2025 webinar where we will get deeper into these details. Okay, first up, the new AUR measure. So in collaboration with the CDC, CMS has already identified the need to separate the AUR surveillance measure into two measures to clarify reporting requirements and incentivize greater data reporting from hospitals in 2025. So because AU and AR reporting rely on different data sources, such as EMAR for AU and lab information systems for AR, CMS also believes that separating the measure into two would be more appropriate because it would target the availability of exclusions for hospitals that may have difficulty with data transmission using a single data source. So CMS believes that separating the AUR measure into two will encourage participation from hospitals that could report data for maybe only the AU measure or only the AR measure that might previously have been excluded because of their inability to report both AU and AR as required by the current measure. So under the current policy with a single AUR surveillance measure, hospitals that meet the exclusion criteria with respect to reporting data of one kind, for example, the AR, are excluded from all AUR surveillance measure reporting requirements, even if they can report data of the other kind, so AU. Offering a complete AUR surveillance measure exclusion, even when participants could report either or, is contrary to the goals of the public health objective because it discourages the sending of partial data as available. CMS has adopted 3 eligible exclusions for the proposed measure, including a new exclusion for hospitals that lack discrete electronic access and to data elements that are required for reporting. And then lastly, and this one's important, back in 2023 in that IPPS rule, CMS finalized a policy for public health reporting measures to limit the amount of time a hospital can spend on option one. And I reviewed that with you a few slides ago. So as finalized, this limitation applies beginning with the 2024 reporting period. However, since CMS has now modified this AUR surveillance measure by separating it, they're going to treat these two measures as new measures with respect to active engagement beginning in 2025 and subsequent years. So this will offer hospitals an additional year to gain familiarity with reporting in the NHSN module before they're required to be in validated data production. Next, CMS intends to continue to align the ECQM reporting requirements and measure set for the Medicare PI program with the similar requirements under the hospital IQR program to the extent feasible. They've adopted two new measures and modified one for 2026. They have also increased the number of mandatory ECQMs to a total of 9 in 2026 and 11 in 2027. So things to just be aware of looking ahead. And then finishing up this section, all the way back in the 2019 IPPS final rule, CMS adopted a performance-based scoring methodology for hospitals, which included a minimum scoring threshold of a total score of 50 points or more that hospitals had to meet to satisfy the requirements. In the 2022 rule, they increased that minimum scoring threshold from 50 to 60 points. In 2023, they extended the 60-point threshold through 2024. In this most recent ruling, CMS has now increased the performance-based scoring threshold for hospitals for the Medicare PI program from 60 to 70 points beginning next year in 2025, and then from 70 to 80 points beginning in 2026. Their review of the 2022 Medicare PI performance results found that 98% of hospitals that reported to the program successfully met that minimum threshold score of 60 points, and that over 80% of hospitals exceeded 80 points. So given the widespread success, CMS believes that by adopting a higher scoring threshold, it's going to incentivize more hospitals to align their health information systems with the evolving industry standards and encourage increased data exchange. So they've noted that hospitals gain 3 years of experience in 22, 23, and 24 at that 60-point minimum threshold to improve performance. So they believe this increase from 60 to 80 points will encourage higher levels of performance. And then lastly here, as you know, in the 2022 IPPS rule, CMS adopted the Safer Guides measure. In 2022, the reporting for Safer Guides was required, but hospitals were not scored. And an attestation of yes or no were both acceptable answers without penalty. In the 2024 rule, CMS finalized a modification to require hospitals to attest yes to having conducting that annual Safer Guides during the calendar year to be considered a meaningful user. They received comments regarding recommending that they work with ONC to update the Safer Guides, citing that they were last updated in 2016. So in response to these comments, CMS noted in this rule that while the current Safer Guides reflect relevant and valuable guidelines, they are considering exploring updates. So future updates to the Safer Guides will be provided with accompanying educational and promotional materials to notify hospitals, and this is going to be done in collaboration with the ONC, the Office of the National Coordinator. In this rule, they were just seeking to make us aware that there are efforts underway to update those guides. And they did say they anticipate that these updated versions of the Safer Guides may become available as early as 2025. And they're encouraging us to become familiar with them and use the updated versions of the Safer Guides whenever they come out. So more to come on this one. All right, lastly today, let's go ahead and review some action items and reminders as we wrap up program year 2024. This slide provides a good summary of what I've covered today for program year 2024 and an overview on the timelines. So the reporting year began on January 1st and it will end on December 31st, 2024. During that time, hospitals must select a minimum 180-day period from which they are able to collect data and then successfully attest using the CMS Hospital Quality Reporting System. Usually those attestation screens become available during the first week of January. I did read this year, it looks like they're going to open up on January 2nd, and the attestation submission deadline is February 28th, 2025. I'll also point out the hardship exceptions. CMS understands that there may be circumstances outside of your control that might make it difficult for you to meet the Medicare PI requirements, so they have provided an opportunity to apply for a hardship exception to avoid the downward payment adjustments. Simply lacking CERT does not qualify a hospital for a hardship. They are granted on a case-by-case basis. To be considered, hospitals must complete and submit an application for review and approval by CMS. And if approved, that hardship is only valid for one payment adjustment year, and CMS only offers a maximum of 5 hardships per CCN lifetime. And those applications become available after the fact. So you don't have to do anything before, it's just in the following year you would file for that. But again, none of our client hospitals will need to worry about those because you are all high performers. So let's see, this participation checklist is a great resource. I think it summarizes the program really well. For 2024, hospitals are required to report on all 4 PI objectives for a minimum of any continuous 180-day period, using the 2015 edition Cures update criteria to meet that CERT definition. Hospitals must report on 3 self-selected ECQMs and 3 mandatory ECQMs for the full calendar year. And then lastly on this checklist, hospitals must conduct or review an SRA during the calendar year. It doesn't have to be, again, in the reporting period, but during the calendar year, and your safer guides as well. And for the safer guides, after you complete that initial assessment, the goal really is that you don't have to complete the full assessment from scratch each and every year, unless you're working with a new vendor or you've had some major updates to your EHR system. So at least for this year, after you completed that initial safer guides assessment, you can just go ahead and update that annually. All right, and that brings us to attestation submissions. So again, this year you will use the HQR web-based system to submit data for the Medicare Promoting Interoperability Program. We do encourage you to submit your 2024 PI and ECQM data early during the submission period. As a reminder, you enter your HARP user ID and password to log into HQR, and they have mandatory password resets pretty frequently throughout the year. So be sure to test your login now. That way you avoid any hiccups when you log in to complete the actual attestation. Now we tend to see this every year. Also, different users have assigned user roles. So just be sure that you are the authorized representative responsible for your hospital's attestation, that you have the proper access granted under your user profile. This is something that the service center, this help desk can assist with, but then you often run into some delayed wait times, and it can be a process, and then that can push back your submission. So just if you get a chance, log in and double check all that now while you're thinking of it. Data for the Medicare PI program can be submitted any time in any order during the submission period, and the values can be changed and resubmitted as many times as you need to during that submission period up until the deadline of February 28th. So, as usual, we will assist with attestation submissions. So, once you have decided on your reporting period, please send your PI reports. We will review your data and complete a final gap analysis. And then we will schedule a screen sharing meeting to assist with your PI submission and help guide you through the attestation. And with that, I sincerely thank you all for your time and attention today. If you have any comments about today's presentation, or if you have any questions about any of the requirements for program year 2024, please reach out to Robin or myself. Again, don't forget to send your PI report so we can take a look and update your gap analysis prior to your attestation submission. Also, please let me know if you would like to set up a call or have a touch base meeting between now and then, and I'll be happy to schedule something for us right away. I know it's a busy time of year. If we don't talk to you before, we wish you all happy holidays and a very Merry Christmas. Hopefully everyone is able to enjoy some much deserved time off. And we look forward to catching up with you all and assisting with your attestations early in the new year. Okay, thanks everyone.